In this lesson, we will cover concepts related to pre-exercise screening. Pre-exercise screening is used to reduce client risks and pave the way for personalized program development. Its primary purpose is to identify factors that may increase the risk for injury or negative outcomes. Primary risk examples include smoking, obesity, chronic low back pain, or the presence of disease such as diabetes or asthma. Compounding or secondary risk examples include poor dietary habits, unmanaged stress, poor sleeping habits, or musculoskeletal imbalances. Failure to screen places a significant legal liability on the fitness professional and their place of employment, as many clients will possess some controllable or uncontrollable factors which increase their risk for harm in response to exercise inappropriate for their condition. The term liability indicates a state of being responsible for something or someone by law. The presented strategies can help reduce overall risk with new clients. The trainer should make sure to identify all inherent risk factors and environments unsuitable for training, thoroughly screen any exercise participants, provide a structured acclimation period to training stresses, prescribe training activities within each client's personal abilities, avoid any activity when the client is injured, and certainly make sure to have an emergency plan in all training scenarios. Let's progress by taking a look at how to implement pre-exercise screening strategies to compile useful data on the client. The first step includes using a number of forms which help clarify their specific needs. These can include an informed consent, PAR-Q+, health status questionnaire, and behavior questionnaire. For some clients, the use of a medical referral form may also need to come into play. Key benefits of pre-exercise screening using these forms include educating the client concerning their relative health risks, identifying the client's current health status to recommended ranges to see where they really are and need to improve, obtaining data that will be used to create a needs analysis, as well as lay the framework for personalized program development, establishing starting points and predictions of performance potential, and identifying the client's specific interests, aptitudes, and possible limitations. Let's continue by taking a closer look at each important screening document, beginning with an informed consent. The informed consent is a necessary baseline contract between the client and trainer, and stands as the first line of defense to waiver liability in the case that something unforeseen happens to a client while training. The informed consent does not protect against trainer negligence, however. Being negligent indicates a failure to comply with standard protocols or use reasonable care, which potentially results in damages or injury to another person. The major components of an informed consent include a description of training purposes, assumed risks of participation, realistic expected benefits of training, an explanation of testing and training procedures and physiological expectations. The client should also have a chance to ask any questions they have before moving forward, the right to refuse training services, and an affirmation that a client's data will remain confidential. The informed consent does not serve to provide data used for program development, but it is a necessary first step to develop a formal contract between the exercise professional and the individual receiving services. Next, we have the PAR-Q+, which includes significant updates and improvements from the previous PAR-Q form used over the last few decades. PAR-Q+ stands for Physical Activity Readiness Questionnaire for Everyone. Its primary objective is to identify clients at risk for a dangerous cardiovascular or metabolic event. It uses 7 baseline questions that reveal risk factor red flags to serve this end. If the client answers yes to any of the 7 questions, a number of follow-up questions are used to see if they need to obtain medical clearance from their physician before exercise. The PAR-Q Plus does not obtain a great deal of info for personalized program development, but it does a really good job of revealing dangerous risk factors that must be addressed. Continuing forward, we have the Health Status Questionnaire, one of the most useful screening documents at the exercise professional's disposal. The Health Status Questionnaire allows the trainer to obtain detailed background information on the client. It should be implemented via interview format so that probing questions can be used to enhance data collection. This also helps to develop trust and rapport with the client. The Health Status Questionnaire is usually divided into separate sections including general client information, current medical information, self-reported health status, self-reported physical fitness, and psychological considerations. The form in its entirety greatly helps to reveal areas for improvement and major risk factors. Data is often categorized on the form with specific action codes such as RF for risk factor or MC for medical clearance to allow rapid analysis after the interview. There are numerous risk factors to look out for when implementing the Health Status Questionnaire, but common examples include a family history of disease, smoking history, a sedentary lifestyle, obesity, high blood pressure, the current use of medications, previous injuries or surgeries, blood lipid profiles which increase the risk for cardiovascular disease, and impaired glucose tolerance associated with diabetes. Directly following the Health Status Questionnaire, the exercise professional should use the Behavior Questionnaire to help connect the dots between the client's risk factors and the daily behaviors potentially promoting them. The combined use of these two documents provides the majority of data utilized to form a program game plan. The Behavior Questionnaire should also be implemented via interview format. It is most useful for identifying obstacles to program goals and factors impacting the client's current health status, providing an opportunity to educate the client concerning how their behaviors are affecting their health and well-being, and identifying appropriate behavior management strategies. The Behavior Questionnaire is very important as unhealthy behaviors engaged when not working with a trainer can make or break a client's goals. Just think about it this way. There are 168 hours in a week, but many clients only spend 2 to 3 of those hours with a trainer. This creates major room for client error that will impede goals without appropriate education. After using the necessary screening documents, the exercise professional must logically compile the data to correlate findings and develop a personalized training program. Remember, major things we were looking for included medical problems or diseases, signs or symptoms of diseases, and characteristics or lifestyle behaviors that increase health risks. As a basic example, if we found out our client is hypertensive, their long-term weight measurements indicate creeping obesity, and they consume excess salt, we now know dietary education and a weight loss program will be needed. Creeping obesity describes an incremental increase in weight over time, often caused by sustained caloric intake combined with a decrease in physical activity. Once we have identified the client's needs, we can then devise a needs analysis, which essentially serves as a to-do list for the client. Needs and risks should be ranked by order of significance to give a clearer picture of program priorities. The needs analysis is usually devised after the use of screening documents covered previously, as well as pre-exercise tests to be covered in a later lesson. In the example presented, we find the client is hypertensive, pre-diabetic, and has high body fat. These would certainly be primary needs considering their association with disease and the potential for premature mortality. It does not matter how fit you are if your life is cut short by a debilitating disease. We also see the client is inflexible, has low cardiovascular fitness, and possesses strength imbalances, which increase the risk for joint injuries. Finally, via the use of the health status and behavior questionnaires, we know the client needs educational assistance in managing stress and improving their diet. As seen, each need has a specified remedy. These remedies build the foundations for program development, which will be covered in a later lesson. This concludes the lesson on pre-exercise screening. In this lesson, we will cover concepts related to exercise testing methodology and goal setting. Data obtained from the resting tests and pre-exercise screening documents will dictate testing and programmatic freedom for each client. This freedom will fall into one of four categories: an unrestricted program, where the client can perform any exercise tests or activities; a modified program, where the client may need some activity modifications to match their limitations; a supervised program, where the client requires full supervision and various activity modifications due to significant health risks; and a medically supervised program, where the client must have medical clearance due to serious health risks and the trainer must abide by their physician's recommendations. Remember, medical clearance is not meant to be a barrier to exercise, but it is required as it greatly limits liability. After a client is cleared for exercise testing, the first step is to figure out what test to use and why. There needs to be logical rationale behind each test chosen, where the trainer is simply wasting the client's time and effort. The justification for implementing any given test can include identifying starting points, strengths, weaknesses, and special needs, determining physical and psychological readiness for certain program activities, and educating the client on what realistic goals may look like for them. As it relates to which test to use, a number of questions must be considered, such as, is the test valid, reliable, and able to provide useful data for programming? Does the test match the capabilities of the client? In other words, is it safe? Does the test have any part to play in meeting the goals of the client? And how will retests down the road impact the client's exercise program? Essentially, all chosen tests must have a useful purpose, match the client's abilities, and play a role in program development. Tests need to be valid and reliable, or they don't serve much of a purpose. A test is considered valid if it has the ability to accurately measure what it is designed for, and it is considered reliable if it has the ability to allow for consistent reproduction of measures during retesting. Trainers should take steps to optimize testing validity and reliability to get more accurate data. Increasing validity involves strict adherence to protocol, measurements, and use of a scoring system, ensuring tester and client proficiency, psychologically preparing the client, making sure all equipment is functioning and calibrated, and ensuring the environment is safe and ideal. Factors to consider here can include the ambient temperature and/or humidity, noise or distractions, and even pollution. Increasing reliability, on the other hand, requires the trainer to duplicate all pre-test and testing conditions, such as using the same warm-up, equipment, protocol, scoring system, and motivational factors. Furthermore, don't underestimate the usefulness of practicing a test before performing it with maximal effort. Practice allows for greater testing economy and confidence on behalf of the client, and allows the trainer to better predict the client's abilities to set up the test accordingly. Testing efficiency can be further optimized with the use of pre-test checklists for both the client and trainer. This makes sure everyone involved knows how to best prepare prior to the event so that no unthought of factors potentially impact its accuracy or reliability. When implementing a battery of various tests on the same day, the personal trainer must put them in the correct order, or results can be greatly skewed. In many cases, testing is more effective when split up on different days. Strength, anaerobic capacity, and aerobic tests are best implemented independently. If all tests need to be performed in the same day, this order should be followed. First, perform resting and non-fatiguing tests, such as body composition or flexibility, then strength, power, and speed tests, such as a vertical jump, then anaerobic endurance tests, such as push-ups until failure, followed by anaerobic capacity tests, such as a 400-meter shuttle, and finish with aerobic tests, such as the 1.5-mile run. This order allows for minimized pre-fatigue due to the metabolic pathways used. Phosphagen-driven and neurally demanding tests are performed before glycolytic or aerobic-based tests for best results. When all testing data is collected, it must be analyzed to contribute to personalized program development. Test scores are compared with established age and gender-specific norms, or averages, so the client understands their strengths and weaknesses and the logical path their program should take. During this process, the trainer should make sure to use tact when explaining any subpar scores. Emphasize that the results are starting points and that improvements will occur. Try to avoid the use of demeaning terms, such as bad or fat. The end goal of testing is to develop a needs analysis for the client. This is essentially their to-do list. A 2-column listing system, which matches each need with suitable remedies, is useful for quick reference during goal setting and tracking improvements down the road. Once a client's needs are recorded, the trainer combines this information with their personal motivators and other factors to create their program goals. Goals should reflect controllable behaviors and be specific, measurable, realistic, and rewarding to the client. They must consider the client's capabilities, the appropriate time period for attainment, and the necessary effort required by the client. Goal attainment will usually follow a building block approach. Daily objectives must be met to progress towards a defined short-term goal or goals, which must be met to eventually attain the long-term goal. Trainers should recognize the most common goal-setting errors and seek to avoid them. These can include creating an unattainable goal or setting an unrealistic timeline, such as losing 10 pounds in a week, which could be possible but would likely require unhealthy strategies. Creating an unclear or intangible goal, such as losing 3% body fat versus getting more toned, and failing to strictly emphasize daily objectives. Remember, these are the foundations of long-term goal attainment. This concludes the lesson on exercise testing methodology and goal setting. In this lesson, we will examine factors that can impact one's fitness level and risk for injury. There are various controllable and uncontrollable factors that can impact fitness potential and health. Genetics, or one's inherited characteristics, includes the uncontrollable factors which impact how healthy, fit, or long-lived a person can be. Genetics dictate about 40 to 66% of factors to impact health and fitness, leaving up to 60% of one's potential to controllable factors, such as their daily habits and behaviors. This should give hope to anyone seeking to improve their health and well-being. Basic factors to impact fitness, as presented here, include genetics, sex, age, environmental factors, such as pollution, one's social circle, stress levels, nutrition, levels of daily physical activity, education, and economic status. Some of these factors are influenced by personal interests, such as physical activity, one's work environment, such as stress levels, and learned behaviors during youth, such as nutrition. As it relates to social elements, if one's friends or family are more physically active, this will tend to have a positive impact on daily activity, but also vice versa. There are also general correlations between a higher attained education level and/or economic status and having a lower risk for poor fitness levels. Knowledge and means essentially allow one to take better care of themselves. A sedentary lifestyle, followed by genetics, can have the largest relative impact on fitness. Being sedentary means following a lifestyle behavior pattern characterized by very little physical activity. Those who are chronically sedentary should take heed of research by the World Health Organization, as well as numerous other entities, which indicate that physical activity improves psychological well-being, function, stress levels, and overall quality of life. Making a habit of being physically active across the lifespan also allows one to remain independent for a longer period of time as an older adult. It pays you back in significant dividends. Furthermore, it has been found that the predominant causes of premature death in developed countries, such as the US, are from controllable diseases, namely those that can be controlled in part by physical activity. Now, regular exercise can clearly be beneficial, but it is certainly not without risk, especially for novice clients new to working out. We find that new exercisers have an increased risk for strains, sprains, and bone fractures when not properly acclimated to the rigors of a fitness program. Strains include damage or tears to tendons or muscle, while sprains include damage or tears to ligaments. Sprains are much more difficult to recover from, as ligaments have limited blood supply and lack of other mechanisms to expedite healing. In general, lower extremity injuries are the most common, namely at the knees and ankles. Metabolic injuries, or thermoregulatory issues, are also real problems to try to avoid. Common examples include hypo or hyperthermia, hypo or hyperglycemia, hyponatremia, or other electrolyte imbalances, and rhabdomyolysis. Hypothermia indicates a dangerously low body temperature, which can lead to diminished neuromuscular control, frostbite, or even death. Hyperthermia indicates a dangerously high body temperature, which can lead to heat-related illnesses such as heat cramps, heat exhaustion, or heat stroke. Signs and symptoms must be looked out for when training in hot and humid environments. Hypo and hyperglycemia indicate dangerously low and high blood sugar levels, respectively. These are major concerns among diabetic clients. Hyponatremia indicates an abnormally low plasma sodium level, which can be caused by excessive water consumption and is most commonly seen during endurance or marathon training. Finally, rhabdomyolysis, or rhabdo, is a potentially life-threatening condition resulting from the destruction of muscle tissue and subsequent release of muscle fiber content into circulation, which can cause organ failure. Rhabdo usually only occurs with extreme program intensity and negligence. With novice clients, the combination of low carbohydrate intake, dehydration, and very intense training in a very hot environment greatly increases the risk for this dangerous condition. Here we see some common injuries associated with popular activities. As one would expect, they reflect the repeated movements or postures involved while performing them. Jogging and running increases the risk for connective tissue injuries to cartilage and tendons in the lower body. Tendinitis refers to inflammatory damage to tendons and is often expedited by overuse. Shin splints in the lower legs and plantar fasciitis, a sharp pain felt along the bottom of the foot, are common complaints due to repetitive microtrauma to tissue in the area, as well as fascial restriction. Endurance cycling can place aggravating pressure on specific locations throughout the body based on the postures used for extended periods. This can impact nerves in the arm, promote lower back pain, and create issues at the hips and ankles, such as seen with Achilles tendonitis. Swimming can increase the risk for shoulder issues, such as impingement, due to repeated overhead movements performed during strokes, while aerobic dance can cause issues in the lower legs and feet, similar to running over time. Finally, for the examples provided, tennis has the potential to cause issues at the elbow, such as epicondylitis, and other forms of tendonitis due to repetitive high-speed swinging of the racket. This concludes the lesson on factors which impact fitness and the risk for injury. In this lesson, we will cover concepts related to resting assessments. A resting battery of assessments can include heart rate, blood pressure, body composition, height, weight, and body mass index, or BMI, a postural evaluation, and a possible referral for blood lipid profile. These resting measurements provide useful data for program development and limiting liability. Let's begin by taking a look at how to take a resting heart rate. Resting heart rate reveals a client's cardiovascular fitness. Deconditioned clients may have resting heart rates that exceed 80 beats per minute, while fit clients can have resting heart rates in the low 60s. For clients with a high resting heart rate, their measure can be lowered over time via aerobic exercise, weight loss, and stress management. Note that when taking a resting measure, there are a number of factors outside of fitness level that can impact the reading, such as lack of sleep, dehydration, medications, stimulants, including coffee, alcohol, and testing stress. The radial artery is an easy location to measure the resting heart rate. Have the client seated with their arms supported for at least 2 minutes to make sure you are taking a true resting measure. Palpate the radial artery at the wrist with the index and middle fingers for 60 seconds and immediately record the heart rate. Multiple recordings over different days can help find an average. If the value is consistently over 100 beats per minute, the client may need to be referred to a physician before starting an exercise program. Personal trainers can take a resting blood pressure measurement if they feel comfortable with their technical proficiency. However, note that trainers cannot diagnose hypertension. If elevated values are consistently measured, they need to refer the client to their physician. Remember that high blood pressure can result in numerous health issues, such as heart disease. It is indicated by any systolic measure over 130 millimeters of mercury or diastolic measure over 80 millimeters of mercury. Another of the common resting measures, the blood lipid profile, can only be performed by a medical professional. Information gleaned from a client's profile can help direct program goals, namely increased aerobic training, dietary modifications, and weight loss. Healthy goals include keeping LDL cholesterol lower than 100 milligrams per deciliter, HDL cholesterol above 40 milligrams per deciliter for men and above 50 milligrams per deciliter for women, and total triglycerides or blood fats less than 150 milligrams per deciliter. Potential medical refer values can include a cholesterol ratio greater than 5, total cholesterol greater than 240 milligrams per deciliter, and total triglycerides greater than 200 milligrams per deciliter. Poor blood lipid profile values also indicate an increased risk for heart disease and related issues. Body composition assessments are some of the most important resting tests a personal trainer will implement, and also the ones many clients will be the most anxious to see their measure for. Personal trainers should seek to estimate body fat using girth or skin fold assessments rather than solely depending on anthropometric data gained from BMI or height-weight scores. BMI is extensively used in research due to its known correlations with diseases, but it does not account for body fat. For this reason, bigger, muscular clients can actually be categorized as obese based on their BMI. Assessing body composition is important, as obesity is associated with many diseases and health issues. It is not just an aesthetic issue. Obesity is classified in stages, with stage 1 presenting among males with body fat greater than or equal to 25%, and females with body fat greater than or equal to 32%. Waist circumference by itself is also strongly associated with disease. Measures greater than 40 inches for males and 35 inches for females indicate a high risk. The waist circumference concept ties in with the first practical body composition assessment trainers should be familiar with, the 2-3 girth body fat estimation test. Girth measurements are preferred for obese or unfit clients, as skin folds are inaccurate and psychologically invasive for these individuals. The standard estimate of error is about 3.5% with technical expertise. For this test, the trainer takes an abdominal and neck circumference measure for male clients and an upper abdominal, hip, and neck measure for female clients. The circumference values are totaled and matched with height in inches to estimate body fat using a specific formula. Personal trainers should also be competent performing a skinfold assessment, as this will be the preferred option for leaner clients. The standard estimate of error is again about 3.5% with technical expertise. For this test, the trainer must first locate the 3 sex-specific measurement sites. For male clients, this includes chest, abdomen, and thigh skin folds. For female clients, this includes triceps, suprailiac, and thigh skin folds. The trainer takes measurements at each location and immediately records the values. The pinch requires the trainer to separate the skin and fat from the underlying muscle with their hand before applying the skin fold calipers to the subcutaneous fat fold. Assess each location twice and wait 15 seconds in between measures. If the measurements are off by more than 2 millimeters, a third measure is taken and an average is calculated. The skin fold values are used in an equation to estimate body fat. Note there are different equations depending on how many sites are used. The 3-site method is just as valid as a 5 or 7-site protocol, with lower room for error. Let's finalize the lesson by covering postural assessments. When implemented properly, they can provide very useful programming data, including risk for injury, chronic pain, or faulty movement patterns, performance limitations, and the need for specific corrective exercises. Common postural deviations can include a forward head position, rounded shoulders, abducted scapulae, thoracic kyphosis, a hyperlordotic lumbar spine, lateral pelvic tilting, and knee or ankle deviations. Static assessments of posture often involve the use of a plumb line from anterior, lateral, and posterior views to expose any bilateral asymmetries throughout the body. Problem areas are noted and incorporated into the needs analysis so that corrective exercises can be planned into the exercise prescription. Posture during dynamic actions such as walking or gait, squatting, bending over, and stepping up stairs can also be assessed. This can clarify what movements should be included into the client's program for improved function. This concludes the lesson on resting assessments. In this lesson, we will cover exercise testing. Let's begin with cardiorespiratory fitness testing. Cardiorespiratory fitness plays a major role in function and correlates strongly to disease and lifespan. Related tests identify the client's VO2 max in milliliters of oxygen per kilogram of body weight per minute. Results are compared with norms to see where the client falls within the spectrum of fitness. Here we see some normative data for VO2 max among adults. For males in their 20s, a VO2 max of about 47 is considered above average, while this declines to a measure just over 35 after age 60. For females in their 20s, surpassing 38 is considered above average, with the value declining to roughly 30 after age 60. It must be understood that all tests come with a level of risk. During cardiorespiratory fitness testing, personal trainers must watch out for red flag signs that the test should be discontinued for safety. Signs that a test must be immediately stopped can include the client's skin becomes pale, or they get dizzy or lightheaded, they experience digestive discomfort or chest pain, they start having a hard time breathing, or they experience a sudden strain, cramp, or inability to maintain the required intensity for more than 20 seconds. There are many cardiorespiratory fitness tests to choose from. The key is to choose the right one for the client's needs, capabilities, and psychological toughness. Common cardiorespiratory fitness tests include the 1-mile walk test, 12-minute run test, 1.5 mile run test, 3-minute step test, and yo-yo beat test. Let's take a quick look at each. For the 1 mile walk test, the client must walk as quickly as possible for 1 mile. The trainer immediately records their heart rate at the finish line for use in an equation that estimates VO2 max. This is a good choice for novice, older, or significantly deconditioned clients. For the 12-minute run test, the client runs as quickly as possible for 12 minutes on a measured track. Considering this test requires maximal effort, it is best suited for athletic clients with higher levels of cardiorespiratory fitness. The 1.5 mile run test is very similar and best suited for the same type of clients. Also on a measured track, the client covers 1.5 miles as quickly as possible. The 3-minute step test requires a 16.25-inch box, metronome, and stopwatch. The client steps up and down on the box at a pace set by the metronome for 3 minutes. This is a good choice for novice or deconditioned clients who cannot perform a maximal effort test safely. Finally, we have the yo-yo beat test. The client performs repeated 20-meter shuttles at a metronome set pace. This is again a good choice for athletic clients with relatively high fitness who are adept at changes in direction and giving maximal effort. Let's progress to muscular fitness testing, including assessments of strength, endurance, power, and anaerobic capacity. These tests can reveal a client's musculoskeletal limitations and areas prone to injury. There are many testing options for this category. We will begin by covering common muscular strength tests, including the multi-rep bench press, 3 to 5 RM squat, 10 RM leg press, and pull-up tests. For the first 3 tests, we use the 3% formula to estimate a max or 1 RM. This formula is very useful to the personal trainer, and it could be recommended to memorize it for quick practical use while working in the weight room. It helps estimate how much weight to put on the bar, so to speak, instead of using guesswork. Let's touch on each test, starting with a multi-rep bench press. This is a good assessment of upper body pushing strength for clients with adequate shoulder function. The reps and weight achieved are used in the 3% formula to estimate their max bench press. The 3 to 5 RM back squat test is very similar. However, this is only suitable for clients proficient in the back squat and dealing with heavy loading during compound lifts. Then the 3% formula is applied. The 10 RM leg press test is also a good assessment of lower body strength and is the better choice for novice clients not proficient in compound lifts that require stability. Again, the 3% formula is then applied. Finally, with the pull-up test, we have an assessment of upper body pulling strength. It is quite simple. Have the client perform as many reps as possible with strict form and record the reps for comparison to norms. Let's continue with muscular endurance tests, including the push-up, modified pull-up, and abdominal curl-up tests. A special note should be made concerning endurance testing. Estimation errors are common due to a few specific issues, including inadequate practice prior to the test, the client is not used to the effort required, the trainer does not make scoring criteria clear, and the trainer allows movement compensations or a limited range of motion during reps. Let's take a look at the push-up test. The client simply performs as many reps as possible until failure, and the total is compared with norms. Reps are only counted with proper form. Females use a bent knee position, while males perform the standard push-up. For the modified pull-up test, the client also performs as many reps as possible until failure with strict form. The total reps are compared to established norms. Males and females use the same form for this test. The abdominal curl-up test is implemented a little differently. The client performs as many reps as possible at a pace dictated by a metronome at 40 beats or reps per minute with strict form. The total reps achieved are again compared to established norms. To finish muscular fitness testing, let's take a quick look at power and anaerobic capacity assessments. First, one should understand the difference between the two. Power reflects the amount of work performed in a given period of time. It is a key component to remaining functional and maintaining independence during older adulthood. Anaerobic capacity, on the other hand, measures the rate of power decline. It could be thought of as power endurance. A few examples include the non-counter movement jump test, 30-second chair stand test, and anaerobic power step. The non-counter movement vertical jump test is used to determine lower body power. The 30-second chair stand test is a good choice for assessing lower body power among older adults. The total reps performed are compared with established norms. Finally, we have the anaerobic power step test, which measures anaerobic capacity. Let's finalize the lesson by covering flexibility and mobility tests. Flexibility is linked to maintaining functional movement abilities, improving performance, and reducing the risk for injuries. Flexibility testing is usually joint-specific, while mobility testing examines cooperative movement capabilities of multiple joints. Let's start by looking at the Apley back scratch test. Here the client attempts to touch their fingers together behind their back. It assesses mobility of the rotator cuff, deltoids, lats, triceps, and shoulder capsule. A good score is indicated by the fingers touching. Make sure to assess each side with unilateral tests. For the modified Thomas test, the client attempts to extend one leg without moving the other leg, which is pulled up to the chest with the knee bent. It assesses flexibility of the hip flexors and also reveals hip capsule restrictions. A good score is indicated if the extended hamstring is in contact with the bench. For the trunk extension test, the client attempts to fully extend their arms while keeping the iliac crests at the top of their pelvis in contact with the ground. It assesses flexibility in the hip flexors and abdominals. A good score is indicated if the hips remain in full contact with the ground. For the trunk flexion test, the client reaches as far as possible between their hips while seated on a bench. It assesses flexibility of the lower back or erector spinae. A good score is indicated if they can get their shoulders aligned with their hips. For the knee flexion test, the client attempts to pull their heel to their glute while lying flat on the floor. It assesses flexibility of the quadriceps and hip flexors. A good score is indicated if the heel comes in contact with the glute without flexing the hips. For the active knee extension test, the client flexes their hip as far as possible while keeping their knee fully extended. It assesses hamstring flexibility. A good score is indicated by the heel lining up with the hip capsule, or about 90 degrees of hip flexion. Finally, we have the overhead squat test, where the client attempts to perform a full overhead squat while being assessed head to toe for movement compensations. This is a useful assessment of total body mobility. Common errors can include posterior pelvic tilting, hip abduction or adduction, the knees shifting inward or outward, excessive dorsiflexion where the heel's rising off the floor, overarching or rounding the back, having the arms bent out in front of the body, and shoulder blade winging. This concludes the lesson on exercise testing.